This week on the BackTable Podcast.
As otolaryngologists, we aren't often the ones that are having those important conversations with patients, and we have to rely on our colleagues to do so. So it's very different. It's admittedly much more challenging than it used to be, but it doesn't take away from how important it is. It doesn't take away from our mission. When I reflect on what makes me happy, it's that ability to improve the life of somebody else. And that could be Friday afternoon when I'm in clinic, and it could be Tuesday morning when I'm in a meeting and we're making a decision that's going to make the lives of not just my patients, but our health system's patients better.
Hello, everyone, and welcome to the BackTable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Hi, friends and colleagues. We're thrilled to announce the launch of BackTable Plus for ENT. BackTable Plus features bite-sized learning modules created by ENTs for ENTs. The content is designed to be searchable, organized, and easy to digest, making it perfect for our busy schedules. Best of all, it's completely free. We encourage you to explore the platform and share your thoughts with us. Go to plus.backtable.com, plus.backtable.com, and click on ENT courses. Your feedback is invaluable as we strive to make this resource as beneficial as possible. Happy learning, and we can't wait to hear what you think. Now, back to the show. Hello, everybody, and welcome to the BackTable ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and we have an awesome show today. We have a great guest. We have Dr. Sunil Verma. He is a laryngologist practicing at UCI, the University of California, Irvine. He's the Associate Chief Medical Officer for Ambulatory and Associate Dean at UC Irvine Health. And Sunil is here to talk to us about when physicians hold health system level positions. Welcome to the show, Sunil. How are you?
Thank you so much for having me. I'm really excited to be here.
It's a pleasure to have you. I think I told you this once before, but I think I heard you speak at the Osler Oral Board Prep Review course that I took. This was April, I think, of 2013. And I remember being just like blown away because you were just such a great teacher. I learned a ton, and I felt so well prepared, actually, for the oral boards because of that course. And I remember you specifically, so.
Thank you so much. You know, it's funny. That was a position I took after fellowship, really to help train people and get over that anxiety of taking the boards, which was really stressful for me. And it was such an opportunity to meet people that were young and excited. And it's funny how many times people have come up to me and said, I remember that course. So those nights and weekends in Tampa and Indianapolis and other cities that I was in were definitely worth it.
Yeah. And I remember it was half of it was just getting comfortable speaking out loud. You know, when a question's asked you, and you're all of a sudden very conscious of yourself and how you sound. And I thought y'all did a great job of just kind of getting over that. Like, all right, move past that. And, you know, what's the structure? What's the format? How do I get organized in my head about some of this stuff? So it was pretty cool.
Oh, thank you so much. Yeah.
All right. So before we get into it, can you tell us a little bit about yourself and your practice?
Yeah. So I've been in practice. This is going on my 15th year. So I just taking a little bit of a step back. I did my residency at USC after going to college at Dartmouth, and then did fellowship after residency in laryngology at the University of Wisconsin-Madison. I took my first job, which has been my only job here at UC Irvine School of Medicine. And so I've gone sort of through the ranks here, and now I'm a professor here. I used to be a full-time laryngologist. I have to learn to say that I'm not anymore. But I do the full breadth of laryngology, from airway to professional voice, dysphagia, cancer, the whole nine. So I still really enjoy taking care of patients.
And you said you're not doing full-time clinical as much anymore. Is that sort of where you were your other administrative roles and hats for ambulatory and associate dean?
Yeah. So, you know, when I first started practice, I thought I'd be a full-time clinician. And frankly, that's the way I set my practice up and really built our UCI Health Voice and Swallowing Center, and have been and was actually very active clinically. And then certain administrative roles sort of came along the path, and I would just add them on, frankly. I would do those in my spare time, if you would, and continue with a busy academic practice. And it wasn't until this latest promotion or position change in April of this year that things really changed, and I had to step back a little bit from clinical practice. So now I'm 40% clinical, which is still, I would say, quite a bit, see patients in the office 2 days a week, 2 half days. I still do procedures in the office, and I do surgery as well.
That's great. Okay, so let's get into our topic for today. To provide some context, when we're talking about health system level positions, I think of, the chairmans, the division chiefs, I think of CMOs. What are the different positions that are out there, and how is a clinical position like a chairman different than the chief of quality, or do they blend?
That's a great question. So there's so many ways to get involved in a health system and hold a position that is more than the clinical position. You definitely cited, especially sort of the historic academic positions of chairperson, division chief. In some areas, they have medical directors, which would be like the sort of almost like a vice chief of clinical affairs. So someone who doesn't really worry about, or doesn't concentrate rather, on the academic or teaching aspects. And then there's other opportunities as well. So there's opportunities, as you mentioned, with quality and safety, with operations. In a lot of programs, they'll have somebody who really is the liaison for the operating room, which is really important in a group of otolaryngologists. And the list almost goes on. And I think that's one of the most interesting aspects is we aren't really always aware of what's out there and what is a possibility. And we almost pigeonhole other specialists and specialties in those positions of leadership and not us necessarily as otolaryngologists. And I think a lot of that is frankly because we haven't had a lot of role models. Our role models have been the chairs, have been the residency program directors, because in health systems up until 10 years ago, there were only a handful of otolaryngologists that did roles beyond that. So I'm really excited to be doing these roles and that we're going to talk about today and help hopefully inspire other otolaryngologists to do the same.
In a non-academic practice or a private practice, what are some of the other roles that people have? Or is it pretty similar where you're the chief of a service line in a private hospital setting?
Yeah, I would say that these opportunities are not unique to academic medical centers. So many folks that are in perhaps private practice or in a managed care organization like Kaiser, these opportunities do exist. They may come with different names or titles. Otolaryngologists may get grouped with surgeons in general. I would say that health systems are almost all moving in the same direction and having titles and positions and roles that are similar throughout.
You said you've been in practice for about 15 years. What have you seen as some of newer roles, or how have some of these roles changed? What was the, chairperson doing 10, 15 years ago that maybe they are doing more of, less of, something different now?
Yeah, and I think that the question of what a chair does, and not having served as a chair, I can't speak to it necessarily firsthand. But I will say that the role of a chair has really changed, and it varies from organization to organization. In a lot of areas, academic departments or departments would function almost as private practices, managing their own P&Ls. And a lot of that has changed over time to become more integrated into a health system. And so it means that maybe the role of a chair has changed. It's still extremely important, but they're maybe doing less of the day-to-day and thinking more about where the health system needs and wants to go. That definitely does vary by the institution that someone's part of.
In terms of other positions or leadership roles, I think of state medical boards. I think of local and national, medical boards or societies. Do those positions also play a role when we think of health system level positions?
I think it's really important if you're interested in leadership or not interested in leadership to spend time in the organizations that matter to you. I mean, we're lucky to have a really robust Academy of Otolaryngology, head and neck surgery, and certainly does not matter if you're in academics or not. There are roles and positions in that organization. But one of my most rewarding roles, frankly, was a local organization called the Research Study Club of Los Angeles, which is a group of otolaryngologists that I participated in as a resident and then got to be the program director for an annual conference. And I did that my first, 3 years in practice. What was awesome about that was meeting really senior folks like Dr. John House and interacting with him now as a colleague, and then meeting folks in private practice and having the opportunity to interact with guest speakers that we invited. In Orange County, we have a similar organization of otolaryngologists in Orange County. And through that, we get to talk about policy. And actually, we've had folks that have gone to Congress and really advocated on our behalf. And then we have In Orange County, we also have a society of local physicians. And so some of my colleagues participate in that. The advice that I give to people is participate in what makes you happy, not in what you feel that you need to participate, because you'll learn how to interact with others. Most importantly, you'll learn the challenges that other people are facing. And we probably think that what we do is very different than others, but in reality, there's a lot of similarities, even if the practice platform is different, the specialty is different, or the region is different. We're all facing the same challenges. And when we work as a group, we get to address those in a better fashion and learn from each other's than if we do it as an individual.
Yeah, I think you make a great point of spending time on the things that make you happy and not the shoulds. But I would tell you the first few years out, a lot of, you may or may not know what makes you happy. Like, was the local organization a research study club in LA? Was that something that, I don't know, assigned or kind of, hey, Sunil, like, this would be good for you, do it. I feel like that is what kind of how we get tagged to different things early on. So as, somebody, especially the first 3 to 5 years out where you're kind of honing your clinical skills, but then all of a sudden there's this other layer or lens and that you're kind of, I don't know if getting pulled into or, suggested, whatever. How do you navigate that, especially early on, to kind of figure out what makes you happy?
That can be challenging at different times. A lot of times you're sort of volunteered for positions or roles where you're told things like, hey, you need to apply for a grant because that is what will make you successful. I think it's okay to, what I advise individuals is it's okay to try things, and it's also okay to fail and say, I don't want to do that anymore. We're not taught that in medicine. We're taught you always have to succeed. We're taught that there's almost one way to get into med school and one way to become an otolaryngologist, and these are the things you need to say. But that's not the case. I mean, we're a group of individuals with individual backgrounds, and it's really important to understand what makes you happy. And also, I think it's really important to understand that what made you happy in your first 5 years may not make you happy in your next 5 or the following 5. It's okay to have interests that change. And maybe that doesn't necessarily look good on paper, if you will, or it may draw the ire of others. But if you're excited about it, it's important. I think the other thing we don't talk about in medicine enough is our non-medical lives, what we like and enjoy doing outside of medicine. And so it's important as life changes, health changes, family member situations change, that we are flexible as well and allow ourselves that grace of being involved in our profession and stepping away from our profession when necessary. In my experience, I did that. I did a lot of research early on. I did a lot of teaching, like the course where I was lucky to meet you, Gopi. And then a few years later, I said, I don't need to teach this anymore. And it was okay to say no. And so what's in my path, at least, it's not been a straight line. It's been a really curvy, almost like Lombard Street, just a big curvy S that goes from one way to another, but still goes in a certain direction. It was those moments along the way that I feel have made me a much more intentional and better leader now than maybe I would have been had assigned these roles 10 years earlier.
Yeah, that's a great point because it highlights how we evolve. You know what I mean? Like, the goal is for us to keep growing and evolving and not sort of boxing ourselves into one, specific realm. And I've definitely have had a S up and down hilly path, if you will, especially the last couple of years. But to be honest with you, I think it was probably some of the changes or decisions I've made that have really made me step out of what I thought I knew or my comfort zone or what I was used to or what expected of myself was probably some of the best decisions I've ever made, because it allowed me to kind of rethink like who I am now, what's important, what I want to do now is not what it was when I was 32. And that's okay. That's probably a good thing.
You're absolutely right. And I think the same thing happens clinically and surgically. I mean, there were cases that I was doing 10 years ago that I'm not now because we had different people come into the group. I wanted to grow, I wanted others to grow. And so you hand off certain parts of your practice. There may be a clinical need that didn't exist before that exists now. And so it's important to be flexible and understand that the way you start off is not going to be the way that you necessarily are in the middle or in the end. So it kind of reflects on all aspects. If you'd asked me 15 years ago, did I ever think I'd be doing it? Well, did I know what a podcast was? Probably not.
I don't know did any of us really know what that was 15 years ago?
If you'd asked me, were you doing a podcast on being an associate chief medical officer? I would say, what? I don't even know what that position is. And how would I, as a surgeon who likes to use my hands, even want or succeed in a role like that? You learn along the way.
When you went, you're going through your journey along the way, the big question is, why, if I'm busy clinically, I gotta, my family life, my personal life, there's not enough hours in the day. These meetings are usually in the evenings. They're hours, sometimes 2 hours. I don't know if my voice really matters. How do you tell people, why is it important? I mean, we can't expect things to go in our favor or if we're not engaged, but what's the incentive to be engaged in these positions?
Yeah, so I think it's going to come across in most situations as there's a need and an opportunity and an unmet need that needs frankly to be addressed. And so in my organization, it started off with just not having enough clinicians that really wanted to build a busy practice and people asking for help with. My first role was, how do we get letters sent back to referring providers? And that was really important to me because I was a brand new laryngologist. I was the first full-time laryngologist in Orange County. It was really important that I got letters and consultation notes back to any referring ENT in my community. And so I was doing that on my own and printing notes and sending them. And once I found that the health system would do it for me, our first EMR would do it, I got really involved. And I realized if I wasn't going to do it, it wasn't going to be done the way I wanted it to. So it was kind of selfish, to be honest with you. But then when you see a little project become successful and you see that others benefit from your thoughts, then I started to realize, wait, it's not just about me. I actually have ideas that can help others. And I never knew that, right? I knew that I could treat patients and do surgery and help others, but I didn't necessarily know that my ideas of the way things should run could help others. There was also the opposite end, which was I had some really awesome ideas in my head that didn't work because there were regulatory aspects, there were financial considerations, someone had already tried it. So rather than be that person in the OR lounge that was complaining that things didn't work, I wanted to try it out. And once I got the ear of some folks, understand why it did and didn't work. And the way it happened for me was sort of progressive opportunities and not necessarily leadership opportunities, but ways to help the system that helped people that think and practice like me. So I wasn't pulled into things I am now, like improving vaccination schedules, because that wasn't necessarily relevant to our clinical role. But I was absolutely pulled into what equipment we need, how we design our clinical practices, and the operating room. I think another thing that, that really changed it for me was when I was in practice, at first, if we needed a fancy tool in the operating room, you just sort of told somebody, hey, this is really important and it's going to take better care of patients, and they'd buy it. Then all of a sudden, these financial pressures started to happen, and maybe it was early in our state here in California than in others. But it went from just saying it was good clinically to now convincing a group of individuals. And I realized a lot of the individuals on the call weren't surgeons. And once I started to realize that, and it started to limit perhaps some of the clinical tools I had, I realized people like me need to get involved. And that was probably that first sort of moment in my mind or my heart that I said, okay, this is not just affecting me, it's affecting the patients I'm treating and the patients that others are treating.
Which brings me to my next question. What is it specific to us as otolaryngologists in terms of our skills or perspectives that we can bring, especially to a health systems level position or improvement?
So that's a great question. And I've had the opportunity to speak to some different groups about this. I wanted to ask, what makes otolaryngologists good leaders in these roles, or surgeons good leaders? So I obviously did what anybody does now, which is I went to ChatGPT.
What did it say?
So surgeons and otolaryngologists are critical thinkers. They know how to work in a group. They know when to lead and when not to lead. They know how to make change. And that was really important to me. As a clinician, you understand the health system from a very different, and let me say this, very important perspective that others don't. We have to remember as physicians, there are non-physicians leading, multiple, levels of non-physicians leading, many, many more than us. But we have the most unique perspective, which is these are our patients and we know how to take care of them. And it takes a team to do it. It's also important to recognize that. On the other hand, what makes it difficult for surgeons? We like things to get done very fast. We want to cut something out and treat it. And that's not the way administration is. We don't like roadblocks, similar to sort of the point I made earlier. And frankly, there's a financial component to it as well. We're really blessed and lucky to be in positions that in most health systems pay very favorably. And the truth is in administrative medicine that those positions often don't pay as much as a full-time surgeon does. And so you have to take it on your own to decide, is this going to be an impact the way it's set up to affect your financial future? And if it is, that's a personal decision that has to be made. Just like we all make a personal decision as to what subspecialty or specialty practice area hours we work are. And so that can be a disadvantage to surgeons being in in administrative positions. And that's important to recognize. And probably a reason, going back to what I said a little bit earlier, is we haven't had a ton of role models up until now, because frankly, people were in a lot more independent practices, made really good money, and made the differences they needed to make through influence without having to do these leadership positions. And, with increased regulation, the world has changed.
I think you bring up a good point. I mean, my other question was going to be, where do you find support, right? Like, whether you're an academic, private practice, you're taking time away from seeing clinic patients, right? So that means your partners are potentially having to absorb that load. Your OR availability, especially for routine cases, somebody else is going to be kind of absorbing some of that. So it is something that, I don't know, do you have to justify it, or how do you find support? Do you have to have somebody that's, your quote boss, or, that kind of believes in this, or your partner that's like, yeah, this is important too? You need support for this, right?
No one's ever asked me that, and that's a really good point. I think in sort of academic medicine or in a group practice, there's no doubt that when you start to step away from clinical medicine, at least your boss or your chair definitely has to back it. You're absolutely right. There's going to be a time when it's going to affect clinical care that they have to be able to support it emotionally and sort of physically and time-wise. In our practice, I take the same amount of call as everybody else. I think it's important that I'm part of the group, even though I may not be as clinically active as the others. And yeah, I'm so lucky to have amazing partners that I lean on for situations when I may be out of town, or when we have really difficult cases that I don't have the skill set or necessarily maybe time always to be able to handle. So you're absolutely right. And then there's also probably what's going on at home, right? You just mentioned the fact that this can be a night, sometimes it can be a weekend job, just like medicine can be, clinical medicine. And so making sure that you're shored up and supported at home in order to be able to do this, because you got to have other people involved in pushing for you, and it's not always going to be easy. But you bring up a really excellent point. And this is kind of something to think about for maybe the folks that are, you don't necessarily have to even be newer into your practice. If you're thinking about roles like this, one really important thing was I had a chair that was incredibly supportive when I decided that I wanted to get my MBA. So in 2018, I started on my MBA here at UCI. But that meant that I think I was thinking about it for like the last 3 to 4 years before that. And so that was something that really needed to be carved out and have support of the chair. So Dr. William Armstrong, who was my chair at the time, is still a colleague of mine, was incredibly supportive. And it was that support that allowed me to really jump into this space.
Yeah. I mean, it takes somebody or a culture with vision, I think, that, the short term of, my partner has this amazing opportunity to, get a different degree or, pursue a different leadership role is only going to make everything better. I mean, that takes a certain level of vision, I think, to see that sort of long-term benefit for this. Can you tell us how, maybe whether you have a personal experience or, how you see physician leadership at these health system levels change policy, change practices? I mean, you started with a really simple but not so simple question or problem that you saw was referral letters, getting those out there to your referring providers and physicians. Where else do you see sort of at a health policy level, does this kind of matter?
Medicine has changed since we're in training, and it's going to continue to change. And we have to be advocates for always performing at the top of our license and having the support that we need to provide excellent clinical care. And in the ambulatory space, that means who is the care team that's going to be taking care of our patients? And are we supported so that those patients are taken care of in the best way possible? And so that means, when you need a nurse, do you have a nurse that's there to help you? Do you have those clinical support folks that could be a medical assistant, could be social workers, could be dietary, depending on where you are, even surgical schedulers? Are you supported in the way that you need to provide care? And that's a really important question as health systems any and every health system is expecting more and more out of their clinicians. So I think you just go through the day-to-day struggles that we have as clinical providers, if you will, clinical physicians, and the health system oftentimes is associated with how to address those, be it, frankly, allowing I'll tell you within Epic, there's certain things that you can turn on that make the life of a physician a lot easier, but they aren't turned on for historical reasons, or no one's been there to advocate for it. Or maybe you just need somebody at your right hand to help you. Maybe you need a scribe to help you with typing your notes. It's those sort of things that the health system can provide, and you can negotiate to make your life easier. And if your life's easier, then that means that you can take better care of patients.
That is true. I laugh and kind of smile at that because I'm like, that is true. And yet it is so hard to make some of those changes. And it makes so much sense. I wanted to ask you, in terms of health systems, we had COVID, right? Right? Yes, yeah. We had this big pandemic that hit. How have health systems changed in the last 10 years, especially, during COVID, I guess we can call this post-COVID now, but, 4 years later, where do you see sort of that evolution?
So one thing is health systems are integrating at a rate that we haven't seen before. So it used to be that a health system would be maybe a one hospital or 2 to 3 hospitals. And now you'll see health systems that are tens or dozens or more hospitals. So we see acquisitions depending on the region at a rate that we've never seen before. We've seen the introduction of private equity and venture capital into amassing private practices. So that's a very different type of system that we've seen. We've definitely seen a very flip-flop, if you will, in the number of solo practitioners. So before, where maybe solo or small groups were the majority of practices, well over 70% 30 years ago. That's very much changed to being well under 30% and frankly under 10% in some regions. And then we're seeing penetration of managed care like we haven't seen before. Now, that's been something that California has seen, in Southern California especially, for years, but other areas and regions haven't. So a lot of that means that we're operating in ways where previously, and I don't mean operating in the operating room, but functioning in ways that previously we were thinking more like solo, more of our own interests. And now we have to think, what's going to make the enterprise succeed? How can I, as an otolaryngologist, participate in that and then make myself succeed? And that's really challenging because admittedly, otolaryngologists aren't at the front mind of a health system, right? I mean, you look at the number of us versus medicine physicians or any other specialty, orthopedic surgeons. So just by sheer number, we don't have a lot. We don't participate often in inpatient care. So that is a real moneymaker for health systems. We aren't involved in a lot of the challenges that health systems have, like ER congestion, bed progression, even keeping costs down. Our cost centers are typically not very high. And so we aren't at the forefront in a lot of health systems' minds. And at the same time, we take care of a lot of patients. Our introduction of new patients to health systems is great. And we take care of a lot of critical conditions and are absolutely necessary for a busy health enterprise to run. I mean, without us, you can't have a trauma center or a busy ER or busy operating rooms. So we may not be at the forefront or the top of mind, but we're absolutely critical. And it's important to recognize that when you're in these positions or you're having these difficult conversations with folks within your own institution.
Yeah, I mean, we are definitely helping with a lot of the ER patients, inpatients, ICU, intra-op, OR that are part of planned cases, getting pulled to airway emergencies. I mean, you're right, we're involved in like all aspects of it, and yet the amount of involvement in just one of those may not be as large compared to the internal medicine, right, who's running the inpatient system. So how do we have to think of it as otolaryngologists or as a field to keep up with, some of these changes that have gone on, or to say, hey, our footprint might appear small, but our impact, like you need us. You can't have all these, the services call us. There's special skill sets and clinical experience that we bring to help patient care. What do we need to do as a field, or does that conversation come up?
It does. And I think it's similar both at the local level and also at the regional and national level. And I'll say one doesn't substitute for the other. So we have really important organizations like the Academy of Otolaryngology, like your state societies, like your medical boards, that are important to be involved with. But that doesn't, because you're involved there, it doesn't mean that it's necessarily going to make those changes you need locally. So you can't do everything. And so hopefully within your area, you have people that are interested in one or the other, or maybe both if time allows. I will say, I've really focused my efforts on our health enterprise and our county and my academic medical system. And now at the University of California Health System, which is 5 medical schools and 6 very busy regional medical centers. At the local level, I think just being present and being vocal when necessary has really allowed those concerns that we've had to not be left out, if you will, as otolaryngologists, to keep it in other individuals' minds. The answer, that was a long answer to say, we have to be involved. And the level of involvement may vary by where you are in the situation you're in.
Sounds like for you, it's mostly to really help to make changes or impacts at the local level. What kinds of challenges or tensions have you faced along the way, whether it's the UC health system within UC Irvine to potentially between where you are and the state? Do those things come up?
Yeah, I think that there's one of the big things to remember is like these health systems used to operate on a margin of maybe 3, 4, 5%. And actually, Gopi, after COVID, you had asked what's changed after COVID. We're operating on margins now of health systems at 1 to 2%. At the same time, they're being asked to invest in expanding their footprint to have to expand the market. And what's also changed recently is our interest rates went up. In order to expand, you have to often either use your own money or borrow money. So most health systems borrow money. And borrowing money has become much more expensive than it was 4 years ago. And so for that, all that goes to say that we're under very tight financial pressures, and that raises conflict, right? The truth is that what brings money into health systems are the physicians, right? Patients go to see their doctor, and then that drives all the secondary and tertiary revenue sources, be it imaging, be it infusions, whatever it may be. But it's that interaction of the patient and the physician and the need for that patient to receive excellent health care. And so recognizing that we're sort of the ones that bring in the business, but then also having to understand that we're in a really tight financial situation, that invariably is going to lead to conflict. And it's going to lead to times where decisions that we feel that should be more urgent and more pressing can't be made, or the solution can't be done maybe 100%. Maybe we have to sort of monitor it and do it a little bit less, because financially it just can't happen at a certain time. That absolutely can lead to challenges and frustration, and probably, frankly, one of the reasons why a lot of people don't want to get involved in these spaces, because a lot of times it can be more frustration than joy, or the work that it takes in order to succeed is longer than we feel like it should be.
It makes me want to talk a little bit more about physicians on on the physician level as opposed to the health system level. As much as we've talked about the evolution of healthcare systems, I feel like physicians are evolving in terms of how people want to practice. And, we can talk about burnout and physician retention, or even something as simple as, switching jobs, switching clinical practices, which wasn't as common 10, 20 years ago. So I guess my question is, do we feel that the healthcare system is keeping up with who we are as physicians today and how we're evolving? Because it seems like there's a little bit of I don't know if a disconnect is the right word, or for me, sometimes I'm just like, I get frustrated with the health system or the hospital I'm in, because I'm like, it feels dated compared to what maybe I see the needs are, or what's actually happening when it comes to at ground level when we're taking care of patients.
I do think that it's very challenging to be a physician or any type of clinician at this point in time. It's too bad that, the statistics come out and so many physicians say they wouldn't want their children to participate in this amazing career. And if it wasn't for my dad, who was a physician, I wouldn't be doing what I'm doing. And I absolutely love it. And at the same time, I understand when people say that. It's a really complex situation because there's so many different pulls that we have. There are so many more expectations of us as physicians. Undoubtedly, many of your listeners will affirm that since COVID, the number of messages we've had in our inboxes and the expectation that we answer repeated messages in very short amounts of time has totally changed. And so while the ability to communicate with our patients has improved, it's led to, I would say, expectations that probably aren't realistic to the other focuses that we're asked to have. I think another changing role of physicians has been seeing that the system may not be set up necessarily for us to succeed and also for our patients to succeed. There's so many other determinants of health that are out there that we need to be addressing that aren't addressed in the 5, 10, 15, 20-minute visit we have with our patients. And as otolaryngologists, we aren't often the ones that are having those important conversations with patients, and we have to rely on our colleagues to do so. And that's when I was talking about a care team earlier, a care team that's going to really help improve the health of our patients. So it's very different. It's admittedly much more challenging than it used to be, but it doesn't take away from how important it is. And it doesn't take away from our mission. And when I reflect on what makes me happy, it's that ability to improve the life of somebody else. And that could be Friday afternoon when I'm in clinic, and it could be Tuesday morning when I'm in a meeting and we're making a decision that's going to make the lives of not just my patients, but our health system's patients better. And so that's my North Star.
Yeah. It's interesting because it is kind of being able to flex and look at everything, healthcare, looking at it at different lenses, right? On one hand, how we train, and the reason we go into, most of us, I guess, when you look at all the, personal statements for medical school, it's direct patient contact, right? It's that one-on-one. And yet, when you think about it, health system levels, it's changing things on a system level to help a larger number. And and how we sort of engage or participate in that is very different than what we're used to on that one-on-one in my clinic. I was able to diagnose this, help walk my patient through this, talk to them about this in the OR, whatever. It's being able to kind of really see that impact as different, and yet they're connected, right? And so I struggle with that because sometimes it's hard to kind of make that connection. I mean, when we're like, how do we make the enterprise succeed? It's kind of like, well, some might say, well, does the enterprise care about me, right? Like, I guess, how do you kind of tie it all together? I mean, you explained it a little bit about with, your North Star and your mission, but how do you kind of, if you have somebody that's kind of newer to this, how do you talk to them about this?
So that's really important, and there's going to be that natural push and pull. The fact is I've chosen to participate and practice in this health system, and that's where I'm going to deliver care. So I need the enterprise to succeed. And I don't consider the enterprise as the enemy. I consider the enterprise as a facilitator. And just like any negotiation you have, when you're negotiating with anybody, your partner, your kids, somebody at the airlines, you have to figure out what's in it for them and what's their angle. And in participating in these organizations, it's important to, what I do all the time is I have to put what I call my enterprise hat on. And when I put my enterprise hat on and I look at that problem from someone else's shoes and see the challenges they're facing, be it financial, regulatory, personal, the fact that maybe they had to acquiesce on a lot of other things recently, then it makes my ability to sort of negotiate a lot better. And I have to understand that there's going to be no decision made in an organization that benefits one at the expense of the larger end. I would say when you start multiplying it on the whole, right? There's going to be certain negotiations and acquiescing of things that maybe aren't going to be perfect, but as a whole, we have to move the organization together. But yeah, I mean, in the end, I have chosen to participate in this group practice, if you will, or this academic health system. And so I need for it to succeed, right? And if I choose not to and I want to go somewhere else, then that's a different story. So hopefully I answered that question.
Yeah, no, I think that choice and agency and sort of finding what brings you joy, it kind of circles back to what you said earlier, where you really want to do things that you enjoy doing, and these things might help make the health system better. And if it's something that you don't enjoy, it's okay to try it and keep doing other things. And and it kind of goes back to being able to make choices of, hey, what worked for me 5-10 years ago, there's something else now, or I got a different itch, or there's a different interest or something else I want to do with those skills that I've gained.
Yeah, and I think it's really important to recognize that we have the skill sets as otolaryngologists to participate in these roles. Historically, they haven't been us. Historically, chief medical officers have been internal medicine physicians. Historically, CEOs have been folks that weren't physicians. But look at it now, it's changed. I mean, we have CEOs of health systems that are physicians. We have chief medical officers that are surgeons. We have otolaryngologists that are deans of medical schools. There's so much opportunity out there to participate. And just because there hasn't been a road that has been paved for you doesn't mean you can't and shouldn't do it. It takes a lot to become an otolaryngologist. It's a lot of critical thinking. It's a lot of negotiating whether or not you know it. So people are built for this. And so if it falls within your wheelhouse, absolutely participate in it. And if it doesn't and something else does, participate in that instead. Also, if you don't have time for any of it, then don't, and hopefully you have somebody else advocating on your behalf in the areas that you feel that are important.
Yeah. In terms of when I think of COVID, I think of the rise of virtual meetings. How did virtual meetings versus in-person meetings affect some of these, what's happening at the health systems level?
I think in every organization, there's a meeting before the meeting and the call after the meeting. Unfortunately, before our meetings were maybe a half hour with 15 to 20 minutes to walk between. So you can have more than 6 or so a day. And now it's every half hour stacked on itself. And that isn't necessarily fun. For someone who's very active and gets a little antsy sitting, these can be really long days. And so I think in some ways, it's made us more efficient because we can do things like this. This is amazing, right? Like you and I talking, being in 2 totally different situations. The ability to learn from individuals in other places has been tremendous. I often are meeting with folks at other health systems outside the state or even the country, if you will. But it's made some of the local stuff probably take a little bit longer than it should. It also means that I think we have to take care of ourselves differently as individuals during these days. So I am much more conscious about, standing doesn't do much for me, but I'm much more conscious of taking a break. So I'll actually build in breaks during my day, take a break just to work on my personal stuff, frankly, drop down to the gym and just hang out on the elliptical for 30 minutes or just get that exercise afterwards. Because I've noticed since taking this on 6 months ago, there's days that the number of steps I take are very embarrassingly low. And for me to stay sane and want to participate in this on the long term, I have to have some really individual, I have to take care of myself.
Yeah. I think you make a good point. We're so used to, checking our patients in and going to the OR, we're on our feet, checking our instruments, doing the case or being in clinic and have X number of patients in clinic, you're scoping. So we're very physically active and engaged, and that our day-to-day is usually pretty busy. And so when it is all of a sudden now you're doing stuff that requires more meetings or things that are you're in one place, it's good that you're able to kind of be like, all right, what do I need to do? This is an issue for me. What do I need to do to kind of help me kind of keep sane and be healthy as I do it? So one of the best things that advice or prep actually got there was one position I had for 2 years for a health systems level position. And one of the people, outgoing people, was so kind, was like, hey, let's have a coffee just to kind of, this is my new foray into this. And I don't think I realized it as much as she knew, hey, this is going to be something different, something new. Let me kind of set the stage and kind of help you a little bit. And the best piece of advice, she was like, you definitely want to listen, be prepared. But she said, don't be afraid to try to say one thing, at least at every meeting or every other meeting. It's okay. It just say something, whether it's a question or just, I agree, or what about this? It doesn't have to be long. And then, and I don't think I realized how valuable that was until we started having these meetings. And I think some of it was understanding and engaging into what was actually happening. Because all of a sudden these discussions that you're not really used to hearing or being a part of, or, there's a lot of dynamics happening in the room because you have 10, 12 people of these different, quote, high caliber positions. And so that was good. And then B, just kind of getting comfortable with speaking up a little bit. What kind of advice or how do you sort of help somebody who's either new into this or, hey, this is something that I want to get into, but what's the language or what's the demeanor? What's the, how do I play in the sandbox a little bit?
First, I'll reflect on the advice that your mentor gave you, which I thought that's really interesting. No one's given me that. And the truth is, in a lot of these organizations and a lot of these conversations, the vocal are favored, right? If you're saying something, you're being heard and your opinion is going to matter. I know your mentor never meant this to say something just for the sake of saying it, but definitely being comfortable with your voice and comfortable being heard is important. So recently I've been in very different conversations, and I was reflecting with one of the chancellors, and I said, this is different for me. I kind of have to say things that I'm not used to saying and be a little uncomfortable. And the message I got back was, you're here for a reason. Your opinion matters. Once you're in this role to represent a group. And in my role, I'm here to represent clinicians, mostly physicians, APPs, and patients. And so your opinion matters. And so don't be afraid to say something. And that was really important for me to be, I'll use the word enabled, especially the way you put it at the end there, Gopi, like these higher ups that maybe know more than I do. One other thing I'll say is, if you're interested in something, so I've had roles in revenue cycle. There's certainly some of your listeners I'm sure have roles in education, in training, roles in improving our diversity. Just like any other field you want to get into, you have to understand the climate, and you have to listen and read and ask questions. Ask questions of people after the meeting, and don't be afraid to send an email out and clarify, and find out what's going on in other places. That's also really helpful. One of my earlier experiences was working with ER physicians on their billing and coding practices in a revenue cycle role I had. And I went into it kind of naively thinking I knew exactly how it should go, and was pretty quickly learned from them that, nope, this is the way we do things. And in fact, this is a way 5 other emergency physician leaders at the university at UC level do things. And so that made me realize that there is power in understanding what the climate is inside and outside of your environment. So I'm really quick to lean on that when I have a question that I feel doesn't necessarily fit my barometer. I'm like, this doesn't fit the sniff test. Things aren't right, but let me double check and see if this is the way it is at other organizations. And I've been humbled to find out many times I'm wrong, but then I also feel empowered that many times I am right. I hate saying that healthcare is complex. It's an overused statement, but it is because of all the pushes and pulls that we have. And so understand what's going on in other areas is important. So listening to podcasts like these and others that you're interested in, reading and becoming an expert is really important.
That leads me to my other question. Are there training programs or other resources? Like what are you reading?
Yeah.
What's on your radio?
I think that one important thing is when people want to get involved in the health system level, and I'll say the chief medical officer level, it used to be, I think, that if you're interested and savvy, that was probably enough. And I think it's changed a little bit, that probably the MBA is either important to show that you're interested or frankly a prerequisite at this point. So when I got the MBA, I didn't necessarily, it was like, it's a toolkit that I can use, but I don't have to have every day. But it was also my signal, frankly, to the health system that I was really interested in this. A lot of MD programs have an MD MBA option. There was definitely a difference of getting my MBA later in my career, because it allowed me during the MBA is like a live education. You're with a group reflecting on your challenges and talking and discussing about problems. I never had a boss in med school. So if I had an MBA, got my MBA in med school, the conversations would have been much different than they were in 2018. So I do think that if you're really interested and sort of you look around your health system and you find that folks are having the MBA, it may be helpful. I don't necessarily know if it's a prerequisite, but it definitely signals to others. In terms of what I'm listening to, so there's not that many ambulatory chief medical officers. So the first thing I did when I was interested in this was I went through LinkedIn and I tried to find anybody I could that had a similar title to one that I was aspiring to be. And I reached out. So there's individuals around the country that have definitely helped me and given me some advice. And so that's another thing I would say to your listeners. If you're interested in something and you would be the inaugural person in that role, go find out from other organizations what they're doing and understand the gaps that individual's filling. And so, yeah, to that end, a lot of where I learn is at conferences and meetings. And it's very different than the ENT meetings I used to attend quite a bit. These are really different meetings where I'm learning into the challenges of others and taking that hallway time or the back of the room time to discuss with people, make connections, and learn from them.
What kind of meetings are these? Like, are there specific hospital administration style meetings or?
Yeah, so Becker's has a big hospital administration meeting. There's stuff that my colleagues here at University of California, Irvine go to. There's quality and safety meetings. There's revenue cycle meetings. The meetings are they're very much like academic meetings, and in that people are there to present something, but they're not there to present their research. They're there to present their experience and allow you to learn from others. So I thought that healthcare, we always talk in our health systems, we got to beat the competition. We have to be number one. I thought that healthcare systems didn't share information with others. That's almost like proprietary. But then when you go to these meetings, you find out it's the opposite. Everybody wants to solve a problem. You want to be the first to solve the problem. I don't want to lie. But
that helps.
Yeah. Once you solve it, you're fine giving that secret sauce to others because it'll take them time to implement, and then you go on to your next improvement. The currency isn't papers necessarily like it is in academic medicine or publications. The currency is almost becoming a subject matter expert, being at these meetings and being someone who's known as a problem solver.
That's cool. Well, as we start to round it out, Sunil, any final pearls that you want to leave our audience with?
I think we discussed a lot of interesting information today. Hopefully it's been somewhat of a inspiration for those individuals that never thought of themselves as being in these positions, as being enabled to do it. Absolutely reach out to people in your organization and outside of your organization when you're interested. One of the first conversations I had was probably 8 years ago with our chief medical officer who was exiting. I actually just asked him, what does a CMO do? I didn't even understand it. What do you like about your job? What do you not?
What's your day-to-day? What do you do? Where are you at 8 a.m.?
Exactly. Expanding your sort of perspective on what's out there. So hopefully our conversation enables people to do that. And certainly if I can be of assistance to anybody, please reach out.
That's awesome. Are you on any social media, Sunil, in case somebody does want to reach out? Or they could, of course, reach out to BackTable and we can connect as well.
Probably the easiest is LinkedIn. I've got an Instagram account, which is not very good and not very maintained. That's another challenge, I think, for a lot of us is maintaining the social media accounts. It's an important part of growing our personal brands and representing our interests and our enterprise's interests. But probably LinkedIn is the easiest way.
That's awesome. Well, thank you so much. I learned a ton. I think it's a wrap.
Thank you so much for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.